Um, history, like any other arthroplasty, like hip or knee arthroplasty, elbow arthroplasty as well, was born out of the failures of management, which were placed or which were failed due to non-replacement surgeries. The history goes back up to 1925 and beyond, even in late 1880s. In 1925, the first attempt to replace joint with prosthetic materials were documented. Robineu inserted an anatomical elbow prosthesis consisting of metal and vulcanized rubber. 1941, Birumu used a hinged non-anatomical metal prosthesis. And later on in 1952, Venable published a case report, which was a custom made for a complex fracture. Continuing on, I think it was 1947, Mellon and Fallon started doing orthoplasty for a partial orthoplasty, basically replaced either distal part of the humerus or the proximal part of the ulna with simple acrylic components. And this was secured with wire placed to the holes of the prosthesis. 1970s, McCausland was the one who first took on with hinged constrained processes with methyl mercurate bone cement fixation. He attempted to restore biomechanics of the elbow with an axis pin, required major resection of the humerus, which obviously destabilized the surrounding connective tissue, and increased constraint led to failure of the bone cement interface. So mainly due to the failure in the hinged prosthesis, three designs were evolved, which were basically subcategorized into unlinked, linked, and convertible or modular prosthesis. Unlinked, the commonly used was Soter Strathclyde, Kudo, IBS or instrumented bone preserving. Linked, Kunder Murray, Discovery, very popular. Convertible, Latitude, and Acclaim. So there are many, many more, but I think these are just fair enough to take some as an example. Unlinked or joint resurfacing. The main things are collateral ligaments are absolutely vital, and they have to be preserved to maintain the stability. Success depends on the integrity of the soft tissue envelope and the presence of adequate bone stock to support the prosthesis. Failure of the above two can lead to failure in the prosthesis. The stress across the elbow are absorbed in part by the ligamentous constraints. Unlinked designs demand precise replication of the axis of rotation, and poor component alignment may result in high failure rates. Particularly, surgical precision is extremely vital, and hence the results by Soter and Strathclyde were not replicated by many surgeons across the globe as good as his case series. Soter and Strathclyde is a lovely gentleman. The main processes include deep grooves at the ulnar-humeral articulation. It tries to replicate the human anatomy, and it's characterized by humeral flanges on either side, medially and into the capitulum. A CUDA 5, the humeral component is made of cobalt chrome, and the ulnar component can be either all poly or metal backed. The linked processes, we call it as a semi-constraint, and the stability is through a coupled articulation between humeral and an ulnar component. There is a scope for varus and valgus and rotational motion of about 6 to 8 degrees, and this is the principle of the sloppy hinge. It's believed to reduce stress on bone cement interface, and hence incidence of loosening is decreased. The main advantage of the design is that instability and dislocation are believed not to be very common. The anterior flange from the linked processes does augment or complement to the stability. The radius and arc of curvature of the components in the sagittal plane and the contour of the ulnar-humeral joint in the coronal plane define intrinsic stability. The role of radial head in total elbow orthoplasty has not been well defined, or at least shown that there is no major statistical significance. Conforming polyethylene and metallic bearing surfaces and increased amount of polyethylene in the bushing. There's no long-term data to show that they improve any implant longevity as yet. Conrad Murray has gone into significant evolutions. Starting from 1981, the anterior flange came into scenario, followed by a few years later with the plasma spray beads and also the pin-in-pin axis. In 2001, around 2001, the universal articulation with ulnar plasma spray, but it's 2013, the Nexel was in vogue. The Nexel is slightly different. It's built on foundation of the Conrad Murray. It's different and thicker with vitamin E polyethylene bearing. It maximizes the contact area, therefore led to believe that edge loading and stress may be reduced. Discovery is based on condylar bearing design. The humeral and ulnar stems incorporate the anatomical bowing of the humerus and the ulnar. It's laterally offset to position the articulation in the center of the trochlea. Convertible allows implantation in both unlinked and linked modes. A conversion of an unlinked to linked processes, especially if the processes becomes unstable during the procedure or if instability develops after the surgery, there is an advantage of conversion. The two main processes are the latitude and acclaim. The latitude has an advantage of replacing a radial head as well. The humerus spool to preserve the linear contact with the ulnar component throughout the varus and valgus movement. It was designed from a Canadian concept. And the indications, well, what are the main indications? We talk about the ideal candidate. Who is an ideal candidate? The ideal candidate should be a patient with end-stage disease. He has a painful elbow with a limited range of motion. He has failed non-surgical management. He has intact triceps function and does not rely on upper extremity assistive aids for ambulance, and his expectations should be low and realistic. The elbow orthoplasty was aimed to relieve elbow pain while maintaining a functional range of motion, which has traditionally, like Ram described, to maintain a flexion arc of 100 degrees, likewise a rotation of 100 degrees. In the past, the total elbow arthroplasty was initially or mainly used for rheumatoid arthritis. Now, given the disease-modifying drugs, we are seeing far less and less rheumatoid patients undergoing such procedures. This is also commonly done, or now commonly done for one of the two main reasons is arthritis, either primary or secondary, and ideally suitable for elderly or sedentary people. Acute comminuted distal humerus fractures, distal humeral non-unions not amenable for internal fixation. Less common indications would be for juvenile idiopathic arthritis, a hemophilic arthropathy, and as part of tumor resection and reconstruction procedures. Rarely, it can be considered to be undertaken for conversion from an ankylosed joint, especially if they've had a bilateral elbow fusion. In younger patients, we must and we should consider an alternate treatment, and elbow orthoplasty is not a treatment of choice. Thank you.